here is, as you know, ICSs, we want to make sure that we are delivering the health and equality agenda in terms of priority setting, how it influences service delivery, etc. So really, one of the key drivers is about research work, and that's why we're all here to share our experiences around research work, what things we should be looking at across the region, around learning on best practices, working with academics and working with ICS managers and directors and other key people within the ICS world as well. So this is our second workshop, by the way, so it's really great that we've got quite a few people. We're going to run this in a similar format, but as you know, we had a poll and we decided that two key areas we want to explore today, based by popular vote, is diabetes, and it's great that we've got Professor Melanie Davies, and I'll introduce her shortly, and she'll do a presentation about how could we look at creating a diabetes plan or strategy sort of across our region. Then we'll have a Q&A, then Melanie has to leave. We'll have a short break. Chris will join us, and Chris Weiner, who was in the West Midlands, wasn't in our region, is defected to the East Midlands, but don't worry, we've given him a special concession to come to the Midlands today, and we'll be hearing from Chris, and Chris will be talking about workforce challenges around delivering the health and equalities agenda. So just want to thank everyone, and again, please, any questions or put stuff in the chat as well. So I just want to introduce Professor Melanie Davies CBE, and I think Melanie, we're all familiar with Melanie, but just to remind how important she is, she's a director of Leicester's NIH Biomedical Research Centre. She's also director of the Patient Recruitment Centre, and she's also professor of diabetes medicine. Her research involves looking at the causes, screening, prevention, self-management, and the treatment, particularly around type 2 diabetes. And Melanie is also a principal investigator on a number of large global studies in the field of diabetes, obesity, physical activity, sedentary behaviour, and cardiovascular disease. So I'd like to welcome Melanie. The floor is yours, and I think you have roughly about 25 minutes for your presentation around diabetes strategy. So welcome, Melanie.
So thank you very much, Patrick, and it's great to be here. I will attempt to share my screen and make sure that you're able to see my slides. So can you see my slides okay?
Yes, you see your slides, yes.
Yeah, perfect. So look, it's so thank you very much for inviting me. I'm slightly intimidated by this audience in some ways. I'm not completely up to speed with ICSs and all the opportunities, but and I've been asked to talk about diabetes and creating a joint strategy, and I thought I would just really highlight two areas which I think are relevant to this. Some work that we've done in our ICS around embedding research, and then secondly around the diabetes blueprint. So yeah, okay. So look, what I'm going to talk about is firstly about embedding research into practice, and I thought it would be useful to share some of the discussions we've had in our ICS in LLR, because Patrick mentioned about how important research was for ICSs, and I think that then segues nicely into the work that we've done in the Midlands Health Alliance and Midlands Engine Health around the diabetes blueprint, which is covers both research and clinical service. So I think we were fortunate in our ICS, and I know and hope that David Sisling and Azar Faruqi are on the call, but there was a very early, I think, discussion around the importance of embedding research into practice in the ICS really at an early stage, and lots of work in discussing and pulling together a potential draft strategy around embedding research into practice. So just to pick some highlights out, because it is relevant to some of the work that we hope to do around diabetes across the whole region and across a number of ICSs moving forward. So I think the first thing was to articulate values and vision around research in the ICS, and I think it's really important that research is very close to understanding the specific needs and health challenges and helps to inform the research priorities. clearly around equality and inclusivity, and also in collaborative working. And we are fortunate in our ICS, as many of you will be in the Midlands, to have a very rich research infrastructure, particularly I think around the NIHR. You know, we have the Comprehensive Research Network, which covers all of our regions, and then we have specific bits of the infrastructure, which I think it's really important to map and understand. I think the other thing is that we sort of pull together a little bit of a mantra around this, in that today's research is tomorrow's care. And I think it's always important to remember, particularly with colleagues who are in very busy NHS and primary care and other sectors, the importance of research in helping to inform and improve and evaluate what we're doing in clinical practice. So we spent quite a lot of time trying to describe and baseline the infrastructure, and that's fairly complicated actually. Even if you look at a very discrete region like LLR, there are a number of partners, and these partners intersect between primary and secondary care, community, pharmacy, public health, third sector industry, and also regional partners that go across our region, the CRN and MHA and Midlands Engine Health being examples of some of the regional infrastructure. We then, in this strategy document, which is a reasonably long document, wanted to pull together some examples of research in practice which go across LLR and remind us of the rich infrastructure we have and how that can really impact on informing service. And the one that I think is relevant to the discussions we'll talk about later is, for example, a program called Cities Changing Diabetes, which is a really good example, I think, of a research but also a cross-sector collaboration, which has really pulled together industry, so Novo Nordisk in this instance, a number of other academic partners on a global level. So this is a global network of cities across the world, but also within the city of Leicester, some really exciting programs that pull together faith centres, sports clubs in the community with academic partners, but also primary and specialist care. And I'll talk a little bit more about that, but that's probably quite a good example of how in an ICS we can pull together across the different sectors to really come up with something which addresses something that's important to all of us. The document then goes on to articulate a number of the vision and values and objectives, key objectives, and you can see that they're fairly ambitious and broad-reaching, and talk about the importance of the governance and operational structure, but also patient and public involvement, effective use of data, leveraging and maximising investment into our infrastructure in LLR, maximising collaborative working, but also, as you can see, equality, inclusivity and diversity, which is important for health inequalities, but also for our workforce. And also, you'll also see that there's also a focus on capacity development and the workforce, which is also absolutely critical. So that sort of sets, I think, part of the discussion, which I think is important in understanding the wider agenda. But then I was asked very specifically to talk about some of the work that we've done in the Midlands, convened by Midlands Health Alliance, Midlands Innovation Health and Midlands Engine Health, to really pull together some of the work around diabetes, which pulls together not just the research work, but some service work, and also understanding some of the opportunities. And this was a piece of work in collaboration also with industry, with Novo Nordisk. So just to give a little bit of context here, you know, diabetes is one of the most prevalent long-term conditions. It's often an index condition and contributing to multimorbidity. It's increasing both type 1 and type 2, but particularly I think the focus of this report is particularly around type 2 diabetes, which is what 9 out of 10 people who have diabetes will have, and which is driving the large increase globally, but also has a real association with socioeconomic deprivation, with diversity and ethnic health, and also is very closely associated with the increase in obesity. And it is one of the most significant public health challenges of our time. So in the UK, about 4.7 million people have diabetes. As I said, 90% of that is type 2. It is associated with poor outcomes, particularly cardiovascular disease, but also peripheral arterial disease. It consumes a huge amount of the NHS spend, but also there is a large unrecognised cost which impacts on people, for example, of working age and other societal costs. It's increasing in the younger population, so many people in the clinic that I do now are people in their 20s and 30s with type 2 diabetes. Even in children now we have type 2 diabetes, and that's a complete generational switch from even 10 years ago. And this cohort of people with early onset type 2 diabetes have a much accelerated and higher rate of complications and are going to play an increasing burden on our healthcare system. So if we just look at the Midlands, and we, well, before we get to the Midlands, just look at some of the impacts. So 80% of NHS spend on diabetes is spent on complications, and you could argue maybe preventable spend. An increasing recognition of the very close association with obesity, but also with physical inactivity and sedentary behaviour. A huge opportunity to improve productivity by improving diabetes management in people living with diabetes. And also we know that type 2 diabetes is a proxy of inequality, with much higher levels in areas of deprivation. And, you know, for example, about 100,000 emergency call-outs for hypoglycemia a year, which are incredibly expensive. I think COVID unmasked quite a lot of the impact of type 2 diabetes. So we know that, for example, the outcomes in COVID were worse in people with diabetes, worse in people of Asian and Black ethnicity, and also closely related to obesity levels. In the Midlands, every week diabetes contributes to more than 2,000 causes of heart failure in England, and 420 of those in the Midlands. 1 in 13 adults in the Midlands has diabetes, which is the highest prevalence of any region, which is another reason why we should be working together. Each week diabetes contributes to more than 130 amputations in England, 25 of those are in the Midlands. And over the next 10 years, the Midlands Engine Observatory estimated that improving type 2 diabetes control could improve productivity, because many of these people, and an increasing proportion of people with type 2 diabetes, are of working age. So there was a roundtable meeting which was convened in July of 2021, the Midlands Health Alliance, Midlands Engine Health and Novo Nordisk, bringing together a number of clinical experts and partners from across the community to try and highlight and look at some of these areas, and to try and develop a blueprint which could be used to help frame the discussion of how we could improve health and the socioeconomic outcome for people living with diabetes in the Midlands. We have, I think, a fantastic infrastructure. We've got, it's not been officially announced yet, but we will have 3 biomedical research centres across the Midlands. We punch above our weight in terms of health research, particularly, I would argue, in diabetes, where we have some world-class programmes going on. And if we can pull all of this together, we could perhaps capture and share some key actions and principles which could put us in a good position in the Midlands to really take some of this work forward. So I think this was put together in the blueprint, which has been presented before, but just to highlight that, highlighting as you would expect us to do, and which I have a bias for, but you know, we can't improve really good clinical care unless we really support excellence in clinical research, and we need to highlight the excellent clinical research in the region, and we need to make sure that people living with diabetes in the region benefit from research that we do. That there should be a focus on prevention, and clearly obesity and also physical inactivity and sedentary time, highlighting these early has the opportunity to reduce the impact and consequences of diabetes. And just to remind people that childhood obesity and obesity at a young age is also going to drive the numbers of people that we're seeing with diabetes over the next 10 to 15 years. That people diagnosed with diabetes should be supported by, of course, excellent treatment and care, and we have a responsibility for that. And we came up with a number of recommendations. One was around the creation of regional research networks to inform the development of clinical best practice. And we are fortunate in that our clinical research network has already supported some of this work. So there is a type 1 network which has been supported partly by the CRN and by the Midlands Health Alliance, and also an ongoing work around type 2 diabetes. We need to understand the unique character that we have in a region, the specific health challenges to inform research priorities, and that I think works back to what I presented earlier around what the ICS can do when they're forming their research priorities. We need to invest in regional and local research centres, and I think that's why it's very exciting to have a number of the ICSs across the region to look at how we can harness and amplify the work that might be going on in single ICS, to really amplify that across a region, to really address underserved communities and health inequalities. And I think that's where diabetes, I think, has great synergy here, because clearly it's a condition which, as I said, is a real proxy for inequalities in health. To undertake research to understand diabetes and obesity as chronic conditions, to reduce the impact on individuals, and to support resilience in terms of future things that may hit us. So we've had COVID, but of course the cost of living crisis and what we're facing now also disproportionately impacts on people living with diabetes, and we need to build some resilience into the system. There are a number of prevention recommendations around trying to drive increasing the rates of prevention of diabetes and identification, mobilising community partners to help tailor interventions to those most at risk. And some of the work that we're doing in the Cities Changing programme in Leicester has, I think, lessons that could be benefit across the region, and the use, for example, of the community centres, sports clubs, space groups, councils and working environments. Engaging with the major employers as well is a really important piece. And we've done some work, for example, in terms of interventions for reducing sedentary time in employers, which has, I think, potentially big benefits. A series of recommendations around treatment and care, about identifying those most at risk and making sure that we ensure that care interventions are provide equitable access and improve outcomes for all, and not driving gaps in care. Make sure that we have processes in place to ensure healthcare professionals from a range of disciplines can work together, and using interventions to ensure that the care is delivered at the right time, right care, right time to the right individual. And again, I think harnessing the power of community partners in this long-term condition, because I don't think we have done that well enough in the past. And also seizing key moments and contact with NHS services to educate and to support self-management in people living with diabetes. And as you can see, this was in July 2021, but already really highlighting the importance of the integrated care systems as a new opportunity to join up pathways of care. And that's part of the reason for being here today and to talk about this programme. So thank you very much for your attention, and I'd be delighted to contribute to the discussion.
And thanks so much, Melanie, for your great presentation and some interesting facts, data, and obviously recommendations as well.